Cam asked me to get some videos, and I did this on the last day before coming here, so I'm imposing myself on Cam. So Cam asked me to see if I had any intraoperative or interesting complications that I could discuss. This is going to be very quick. So the first one is a patient, 51, BMI 47, had a staged band and then a SADI in 3 months. The operation went really well. She went home. About 5 or 6 weeks later, she presented to a regional hospital, which is about 200 kilometers away, with very bad pain, physical examination okay, everything was all right, pulse normal, BP normal. They did a CT and reported it as normal. And they wanted to discharge the patient, and the patient refused and said, no, I'm having pain. They thought she was seeking, drugs. And she called me and I said, just transfer the patient. So by the time she came to me 6 hours later, the pulse was increased. Everything was normal. I had a look at the CT scan, and that's a very subtle finding of fat stranding around the D1 area, right? So first lesson, always listen to your patient, right? So I went in because she was not febrile, but she was having a lot of problem. I couldn't find the first video, but what I found was there was no contamination. Actually, I'll just show you this. So if you can see the top fibrotic area and the lower fibrotic area. So that is the DI anastomosis, which was attached to the ligament and to the abdominal wall, right? So it acted obviously as an efferent loop obstruction. And then there was, the D1 had given away, but there was absolutely no contamination, nothing. This was my first experience, was it? Very naive. I thought that it had healed and I have to do nothing. So I just gave it a good wash. Next day in the morning, patient started complaining of pain. I had left a drain in there and there was bile that was coming out. So I was worried, okay, has the duodenal stump given away? Should I go in again, not go in again? But the best thing when you're not sure is go in again. Took her back to theater, and this is what I found. So you will see the abdomen is still clean. You will see the drain there. So I kept the drain in there, which was all really good. And the D1 area also looks good. It's not given away. So looked at onto the other side, there was a lot of bile in that area. So what I did was I put another drain to drain the right upper quadrant as well. And then took the patient back to the ward, started her on IV antibiotics, started her on octreotide. For whatever reason, I thought it might benefit her. So she was well. And I kept her NPO, no fever, nothing whatsoever. Maybe I could have started her on food the same day. This is inexperience. And sent her home after day 5. The drain drained for 6 weeks and then stopped, right? Removed the drain and the patient was well. So that was an afferent loop syndrome caused by obstruction with the D1 stump blowing out. So the next one is also important. So this lady had a sleeve with a minimizer ring by another surgeon. She lost all the weight, subsequently regained it. And I removed the ring first and then did a staged paraesophageal hernia repair and a revisional SADI. And I discharged her the next day. And day 5, this lady was feeling so well, she felt better than what she had with the sleeve, that she wore an abdominoplasty binder. She was living alone, so she wanted to move her furniture, pressed her abdominal wall against the dining table and gave it a heave, and suddenly developed very bad abdominal pain and came to the hospital. So you can see free air under the diaphragm there, and on the other side you can see contrast flowing outside through the duodenal anastomosis area. So there's the pus there. I wish I could, and that's what you see. The DI anastomosis has got a blowout rupture. You can see the stitches, both anterior has given way completely, but you can see the stitches are still intact, right? And when I look at the posterior side, the stitches were still intact. So this was a typical blowout, like a Boerhaav's perforation, right? So what did I do? I made sure everything was okay. There was not much contamination. Gave it a good wash.
Please. Would you like to ask someone on the? Okay.
We waiting for the other people. Or you're okay with it?
Yeah, we can ask the expert on that stage right now. You first.
So this case you did not put a drain, right? Then this after surgery, how many days?
So this is about 6 weeks after the operation. Oh, this one?
Yeah,
this one
this
is
again.
5 days.
5
days
days.
after the operation. Yeah.
Okay, so I think the patient presented without the severe sepsis, only some abdominal pain.
Severe onset of pain.
Then he come back to the hospital. How long?
Straight away, about 2 hours.
So, okay,
Because they
so-
have my number. Patients call me.
Okay. So I think it's a very early onset of the anastomosis insufficiency. So we go in, we wash out. So maybe a little different with the just now I showing the
Yeah.
data. Yeah. So I think the patient in early stage, if the abdomen is quite clear, then if you think that the tissue is still good, maybe repair it. Feeding jejunostomy might be enough. I think.
So I did repair it primarily. And, I kept the patient NPO overnight, did a CT swallow next day. Everything was going all right. Started her on clear liquids, discharged her day 2. And after day 5, she went back on eating solids and she was fine.
Day 2 discharge. Is this okay?
So,
Pour out of anastomosis. I will keep the patient at least 4 or 5 days.
No, that's okay. I think I agree with all the CK said. It depends. If the patient is very ill and is unstable, you can drain and wait and see. And but sometimes, the patient is, the resection of wrong way gastric bypass, as CK said, is a very safe approach to this kind of patient. It depends on the cause of the, sometimes you can see some. Ischemic area in the duodenum and some, less advisable thing for doing conservative, resection the wrong way is another option, very safe in this kind of strategies.
Another thing, Dr. Ravi, I think the patient came to you quite quick, I think. Once the thing happened,
That's
I think the contact at the time when they came, so there's not much contamination there as well. So I think you did a good job in suturing it.
So the next one is why, no matter how much experience you have, surgery and patients can always humble you. So this is a lady who, had a sleeve, and then my regular anesthetist was not there. So we had another anesthetist, and everything was going all right. I did the DI anastomosis stapling, and it was very difficult to staple. And then after I finished it, I found a green line. So guess what? The anesthetist had put a nasogastric tube in, and I've stapled across the nasogastric tube, and I'm stuffed. So we see that in Roux-en-Y gastric bypass. But in Roux-en-Y gastric bypass, it's very easy to remove the nasogastric from the gastric pouch as well as the jejunum, because it's there right in front of you. The problem that I have is that I did a duodenotomy on the side of the pylorus, but I did not want to touch the D1. And I thought I freed everything and that everything was well. This is what we found the next day, that there was still about 5 to 6 centimeters of nasogastric tube still left in there. If it was in the United States, that was the end of my career. But in Australia, there is something called as informed disclosure. You talk to the patient and you tell them you've stuffed up, and then you say, these are the options, what do you like me to do? So I did discuss with Dan Cottam, who had no idea as well. So he spoke to the biggest hepatobiliary surgeon there in Utah, and they said, look, the risk of doing something is very risky, because if you end up with a problem at the stump area, you'll have to put a T-tube and it all, So if the patient's happy, and if you're not going to get sued, give this option and leave it alone. I spoke to the patient, told her everything. She said, leave it alone. And I think it's about 4 years. And I did an X-ray, almost every year for the first 1 year to make sure what's going on. She was happy. She was getting fed up.
What is located?
Hey?
What is placed?
Where is it? It is the duodenal stump area. So when we staple, so half of the nasogastric tube is here and half of the nasogastric tube is here. I removed the one which we had access to, but the rest is in D1 area. The tip is just above the ampulla.
But this where is located?
Hey?
Outside?
Within the because the nasogastric.
Oh, yeah.
We never put a nasogastric tube.
You mean?
Sorry.
Duodenal stump.
Yes.
Oh,
Yes. So I never put a nasogastric tube, whether I do a sleeve, only if I see that the stomach is dilated, we suck it and go out. So I've got a team of 4 anesthetists. One was on leave, new person, senior one. He didn't even tell me, put it straight right in, and I'm stuffed.
Leave it. Yeah. This approach is the idea.
I have first question is why you put NG tube during the
I didn't.
but how the NG tube is in
Nasogastric was put in by the anesthetist. You see, if you have somebody who is not your regular, they don't know what you do. And when somebody takes over, you assume that the anesthetist would have spoken to the other one saying, this is what Ravi wants. But that didn't happen. So we were operating. He's just whacked the tube in, kept quiet until I got, so what the shit?
Okay, this is a good lesson that we would recommend no NG tube for all bariatric patients. It's very rare to see right now. It's happened 20 years ago.
So this is not my first case, right? This is like my 300th case or something. So
Okay.
it can happen to anyone.
I think leave the foreign body, the silicone tube in the duodenum. What I'm worried just about, maybe in the future there will be some like a penetration from the duodenum. I don't know. If it's me, I might still open the duodenum, take it out, then repair it. If it's me, because when it has something happen,
Professor
can
Torres.
erosion to the CBD can cause some of the other issues.
Because it's a foreign body there.
It's a foreign body.
So there are multiple reports in literature with retained nasogastric tubes, feeding tubes broken down and gone to the terminal ileum where you can't retrieve it. Patients usually pass that, and there have been instances where there are nasogastric tubes that are stuck somewhere. Because it is inert, we keep feeding tubes for like ages. Because it is inert and because it was nowhere near the ampulla, the decision was that if I operated and if something went wrong, so handling the duodenal stump area is very difficult. So if you remember the old gastrectomy things that we did, you had to put in a T-tube, it would leak, the patient would be sick, TPN, terrible.
Another very, very positive thing of the SADI procedure, even you have a duodenal stump blow up, you can feed the patient by mouth. So it's going to be a very important, approach. We have some many years ago, and even now, the colleague from Poland, he called me that when this duodenal stump blow out, I was like, feed the patient, put a drain, feed the patient, and the duodenal stump close. Absolutely, going to be one of the advantages of having SADIs. But anyway, I think if you leave this foreign body there, I don't think going to be happen nothing. I always, it depends. There's some problem. We got to solve the problem.
If the acids dissolve and the nasogastric tube falls out, she'll pass it. So I mean.
Yes, Dr. Kidu, what is your opinion?
Yeah, I still, because it's a foreign body there, I'm not sure, how will it behave. But if it's been inert for the last 4 years, then I think your call was right. 6 years. So it's a correct call. Because
Lost weight and she's happy.
Because if you had gone in and opened the duodenum and taken it out, then the risk of a blowout later on, I'm not sure about in Australia how the litigation would be, and as a consequence of a complication. So yeah.
Yeah, I agree with you. If me, I will try to remove it. But it's kind of any foreign body there, maybe something happen after that.
You really can sleep very well.
That's okay. Now we move to the next case. It's a quite simple case.
So it's short 2 cases from our institute. The first one is intraoperative unexpected events.
Okay, the first case, we will show you in the intraoperatively. Skip this page. Okay. So this is quite simple. That we have found every day. If you do the transaction, after transaction, you see the color of the duodenum is become purple, right? This. What if you are a beginner to do a duodenal switch? What would you like to do next?
I think I discussed this before. If you are a rookie, you will shit your pants and worry that the patient's going to have a big perforation the next day because it's not going to heal. But whenever you see a blue, purple duodenum, it is because of venous congestion, right? And it's not because of loss of vascularity. So, and if there is loss of vascularity, when you actually cut to make your anastomosis, the inside of the mucosa will not be pink, okay? So the only reason you will resect or do anything or convert to whatever you want is if the mucosa appears to be unviable. So it is never the case. So like I said, the first two cases I would not sleeve, but I keep getting these regularly because of venous congestion. Don't worry about it. Do your operation, finish, go home, sleep well.
Yeah, I think we have to learn about our old professor. You remember in Brazil, this is a huge experience, doing Duodenal Switch at the beginning, and Marquezini, father, they published a very nice paper, showing us that, if you have the left gastric artery, can irrigate all the stomach. Now, at present time, we have the ICG, can help you in making the decision. But anyway, the mucosa color aspect, the mucosa is going to be essential. But move forward, perform the anastomosis, nothing will happen.
Okay. Boss?
I agree with that. I think if you preserve right gastric artery well, then you see this kind of color. I think I will proceed to do loop DZV. I think no issues. But if you incidental injury right gastric artery, right now only one left gastric artery to supply all the stomach, I will do Y. And then when you open it, if you see the mucosa tissue is still very pink colors without this kind of dark side of the problems, I think that is still very safe. Yeah, so I think you can decide when you open it, then how to do it.
Yeah. So Dr. Pujol is associated with Professor Torres. When I went to see him operate, because they do these laparoscopic DSs from like 20 years and stuff, they just take the right gastric artery. He takes it regularly, so even if the right gastric artery is not there, the mucosa will still survive because the left gastric artery will always, supply the sleeve.
A very important technical nuance is regarding that, the ligation of the right gastric artery. If you ligate it, as Dr. Pujol does and some other groups, you have to ligate the artery in the root where the artery is leaving, or the gastroduodenal artery, or sometimes it's coming from the hepatic artery. So you have to ligate there at the beginning, when the right gastric artery leaves the main artery, because in this way you maintain, the collateral, the loop of the lesser curvature. It's going to be very important. But anyway, I think now ICG can be useful now. We can use it, and in the end, the color of the mucosa. And sometimes even when we convert Roux-en-Y gastric bypass to SADIS procedure, what we do, we can do in two steps. You can do the gastrostomy and don't do the sleeve, and do the duodenoileostomy, and try to leave some time, but the neovascularization of this anastomosis happens, and then if the patient is not doing well, you can come back, some months later, and complete the sleep. And many, many times, those patients don't need another surgery because maintaining this restriction, pseudo-restriction, is going to be more than enough. For example, another example of doing, this a strategical, approach is going to be when we convert vertical band gastroplasty to SADIS. Sometimes this territory is absolutely non-practical. It's a lot of adhesion, and then if there is some patency of the through the band, the ring, you can do SADIs, the duodenal ileostomy, maintain some restriction there, and that's all. So there's different strategy of dealing with a very troublesome situation there.
Okay, thank you. But I heard some surgeon using about ICG that you mentioned. Some surgeons said that don't believe ICG, just believe your eyes. Look at the mucosa. Is it true or not?
That's true.
So I don't have ICG. Okay, I just look at the mucosa, right?
ICG also help you, yeah, at least in terms of be more confident with your decision.
Okay, thank you. So in this case, I'll proceed to do anastomosis. Yes.
But that's not blue at all. You should see the blues.
Yeah. But because I don't have the blue one. I just show the case if you facing with the more blue and purple. The mucosa is good. Yes. So I agree to preserve the light gassing artery.
When you open it,
always,
it's become dark everywhere. Then I think you have to do bypass.
Okay, I agree. Okay, to the next case. Next case. Okay, next case. Okay, next case is also very simple for you, but okay, next case is post-operation for Sadie for 1 year, and she come back with reflux and endoscopy. We show you this. We found a lot of bile in the esophagus, in the stomach, and the bile stain over the sleeve, the post sleeve. Oh, post Sadie's. Yeah, post Sadie's. And the fibrous, you can see, it's still okay. This is hiatal hernia. You want to answer right now, I know.
So, I've had 2 cases like this. This usually happens when patient has had a SADI or maybe even a Roux-en-Y, has lost weight, and then sudden onset of reflux with a lot of pain. So the most common finding you will find is a hiatal hernia, and you will also find your anastomosis lying very close to the hiatus, so it is acting like a vacuum pump and sucking bile in. So I usually tend to go reduce the hiatal hernia. You will find that if the staple line is stuck to the crus and or to the pleural lining, that is when these people will have pain and also inability to eat and drink. So idea is to reduce the hernia completely and then bring it down. Usually it happens because the diaphragm has become weak, loss of muscle tone and all that kind of stuff. And if you want to do a cardiopexy, whatever cardiopexy you want to do, you do that, and the patient is back to normal. So it's because of the proximity of the anastomosis, which is near to the area where the bile is being sucked, right? Otherwise, you should not have bile reflux with a SADI because the pylorus is competent.
This case, I think you have a few choices. That I think if you do CT scan, you will see the gastric tube migration to up the mediastinum, maybe 3-4 centimeter already. And then so to bring it down to chloroplasty, I think is very essential, necessary. But you have a bioreflux issue too. So you have GERD, you have hiatal hernia, you have bioreflux. So if you want to convert to Roux-en-Y bypass, then your distal stomach, if you did not resect it, it still have to carry the long-term issues of entromas, exposure to the long-term bioreflux issues. So for me, I would rather in this kind of case, I will bring down chloroplasty and then loop DJB, I'll convert to Roux-en-Y DJB. Then you can solve both problems. Then reflux gone, then sleep intake, and then bioreflux gone. I would do that.
I think these cases are very challenging, because it's very difficult to correlate, the symptom with the finding. And sometimes you even, well, it's clear the GER. I mean, you can, if the sleeve is migrating upwards and there is some crura problem, you can solve that. But regarding the other symptom that the patient is referring, when we convert standard studies in Roux-en-Y duodenal switch due to bile reflux, the patient still has some symptoms. You know, the symptom related with the biliary reflux is not very clear. Even, you know, we have a couple of cases performed after Roux-en-Y gastric bypass. If we remove the remnant, because sometimes people say it's going to be a reflux to the remnant, these symptoms. But in the end, I don't think we are solving this kind of symptom of the patient, reoperating them, except, I mean, the girl. I mean, if there are some anatomical problem regarding, you know, the migration of the sleeve, some hiatal hernia, some very clear problems, you can help the patient. The other symptoms are not very well controlled by surgery. I think, you know, the patient has his or her brain not working very well.
I mean, my philosophy is less is more. Patient has an anatomical problem, right? So you give the patient a chance. You could recreate the anatomy to normal. If the symptoms are gone away, you're laughing. If the symptoms haven't gone away, then you address the symptoms based on what the anatomy is.
Kido?
Yeah, for me, I feel if, let's say, the patient is symptomatic, and they come back with very severe GERD symptoms, you know, threatening their day-to-day activity and all that, then I think we need to do something. So that's where I think probably correction to Roux-en-Y gastric bypass seems the best option. Yeah.
Yeah, I agree with you guys. But if the patient has a mild symptom, so we will start with the medication first, right?
Yeah.
So what kind of medication in this case? In this case, we send to the GI and endocrinologist, and he do the 24-hour, and they found that only alkaline reflux.
Yeah, I think you can do prokinetic medication and PPI. We don't have any other medication. PPI, prokinetic, I mean, and even some erythromycin or all the prokinetic tool you can have, you know. Mainly the patient going to be guiding you in what is going to be the next step. But in the end, these kind of patients are very tough to improve, to ameliorate their symptoms, is my experience. You know,
So for bile reflux, there are two things that work. One is cholestyramine. So the trade name, I think, is Questran Light. You give 1 pack 4 times a day or with meals. That helps the bile reflux if you want to treat it medically. The other PPI that works, the only PPI that works for bile reflux, which in the past we have used for gastric cancer and esophagojejunostomy, is rabeprazole. It works beautifully with people for bile reflux. So these are the two things that if you want to treat it conservatively, then you could do Questran Light and rabeprazole. So the Questran Light is also the medication that you give post-cholecystectomy diarrhea. Is to reduce the bile detergents, and that's one.
Okay, thank you. We will move to the next case.
Oh, yeah.
Please.
Yes, just to share with you some challenging cases. Cases to discuss with you. First is bleeding. This unexpected finding in the OR. Let me share with you this issue. And what will be the strategy to do that? Look at that. The surgeon is performing a sleeve gastrectomy. Woo! Okay. Let's put in some clips there. It seems it's doing a nice work. What's next? What would you do next? Give the micro to the audience, please. Not the expert. The audience. The expert, no, the audience. The
Lama,
audience.
please.
What to do?
Okay,
Next.
to be honest, it's scary. So the first thing, if I'm there, I'll first compress first, get my breather, and then maybe I need to improve because I think the area is quite narrow now. I need to have a better exposure. So I think maybe I'm not sure whether the short gastrics are fully released or not, bottom and all.
What to do? Another trocar? Ask for help?
Yeah, one assistant trocar maybe for compression,
Okay.
and then try to maybe make sure the fundus is cleared off, get a better exposure,
Okay.
and then I have to locate the vessel, isolate it, and look for the proximal distal.
The surgeon is trying to get better exposure.
I think maybe need.
He's doing his best.
Okay.
Put another trocar. He put another trocar. The exposure is not very good. Oh. With some compression. And then, a strategy when you're performing a sleeve is to invert the approach. To do the sleeve first and to control the ilium later on. So it's going to be a nice strategy. Don't use clips, don't use energy, don't use nothing. Change your way of doing things. Do a sleeve first and then, control the bleeding. So another trick when you are finding with this the final dissection of the recurvator, now you finish all your dissection in this way, right? Okay. Let's go to the next case.
The first thing I would do is to
Okay,
get
so-
the
sorry.
anesthetist to resuscitate me because I would have fallen to the floor.
Excuse me, can you repeat? The first thing is...
The first thing I would do is for the assistant to ask the anesthetist to resuscitate me because I would have fallen to the floor.
Okay, good. And another important thing to do is to ask help. Ask for help. Okay? And the senior would be you do compression. The best hemostatic maneuver is to compress. The compression is basically, it happens in the ward and it also happens in the OR. Compress.
So,
Damage control.
yeah, I've had this once, and it's very difficult. It's usually a short gastric artery that is bleeding, and it's very difficult to locate it. So, you need to have a good assistant, because when you work together, you've trained the assistant that if there is bleeding, you just go and catch whatever it is bleeding. And then, Ligosure is what I use, and I use Ligosure to go, the first couple of times it's blind, you haven't gotten it, but then at some point of time you actually get it. But if that's not possible, I do exactly what you do. Do the
CK.
sleeve and...
What do you think?
Most disease that happen is you did not see anything, but you do everything. This is most of the breather control that what I see from my fellows. This is what I learned from them. They see the bleeding, they're very nervous, but they forget they have boss. They think they are the boss, they try to control everything. So they use Ligosure, harmonic, precision
Right,
going.
right.
Then when they find they cannot control, they use hemoclip here. 1, 2, 3, 4. Then they don't know what they clip. Then still bleeding.
That's right.
Then they go to the wrong way. Then injure the other things. So from short gastric vessel becomes splenic vessels or puncture the spleen. This is what they can do. So when bleeding happen, you must be settled down first, do good contraction. If there is a need for more exposure, you might need more trocar. It's okay. 1 or 2 trocar did not make harm to the patient. Okay? Call more senior or call your boss to join you. Then 2 or 3 senior surgeon can help. then do good exposure, see something, the true vessels, then you can clip. Without seeing anything, don't do anything, compression and wait. Call help. That is the way control the breather.
Absolutely. Compression and ask for help, going to be the most important. Going to be very important lesson too, because it really happened. It's not an invented case. Look at this. Look at this, what happened here. This is a ultrasonic scalpel. It's not a very obese patient. It's I think it's get revisional surgery or something like that. It's going to be. Everything is okay until now. The surgeon saw something, something like a vessel. And again using the ultrasonic device in a very liberal way. A cartoon asked me unexpected situation in the OR. Look at this. Ooh, wow. Another volunteer. What to do now?
In this situation, if you can control on with the left hand, and I think if you can do the stitch.
Stitch.
Yes,
Good.
if okay, that okay. But if wait for few minutes and after that it is worry of breathing, I think if cannot do the repair with the laparoscopy.
What kind of stitch do you use in this case? Are you asking for what stitch?
Do the,
What kind of stitch?
non-absorbable suture.
Excuse me?
Non-absorbable suture.
Absorbable or non-absorbable?
Non.
Non-absorbable, like what?
Proline.
Proline.
Yes.
Okay.
But if you're not open to stop,
Okay.
and then after beating stop, continue to do laparoscopy to do bypass scan, do a bypass scan.
Okay. Do you think going to be to do stitches better than to put some clip, right? In your opinion?
Yes.
Yeah. The surgeon disagree. The surgeon chose clips. It's very brave. I agree. Ooh.
I think he don't know what it is. He had no idea what he's experiencing.
Right.
This one, he is going to do the bypass.
Yeah.
This surgery, he going to do the bypass.
Do bypass, right. Finally, he asked for some help, and and they put some proline over there, and the situation was under control, right? And we were dissecting everything, and to be sure that everything is correct. Another lesson is not to use this kind of device very close to the vascular, and then they put some cleats in the left suprahepatic vein, dissect everything. Can you see here? Put some hemolock there. And then the bypass was finished. Later on, you put some proline there. Can you see? And then the situation was already solved. Some going to be a nice example of unhappened, situation during the OR. You were asking for that, right? Yeah. Yeah, still with this clip, you're going to be maintaining the vessel there. Yeah. And then everything was, after these stitches, you're going to be, and then, the surgeon who performed the lesion that didn't finish the case, okay? He couldn't. And he's the final aspect, the left suprahepatic vein, already. This is the vena cava injury, laparoscopy. Here you can see it's a case report, and then, is how to manage, the situation, and you're going to be, lesson, avoid cautery of the caudal lobe, packing and compression. Again, it's going to be important. That compression is going to be the most important. Sacrocorporal knotting. It's going to be important, not to try to tidy it up, intracorporally, because it's going to be very important. You are losing the tension, and it's going to be very advisable to tie it up extracorporally to maintain the tension of these kind of stitches. And and some other. So what about this other case? Very, very quick case, very fast case. It's a female, 45 years old, study procedure, and you had the divisional surgery there, and the surgeon decided to do some sleeve. Some sleeve here, dissecting everything there, and then we are starting doing the red, the using some buttress stitches. You pass the bougie over there, and then you finish their sleeve there. And when he performed the blue test, here you can see what happened here, right? The surgeon tried to repair with some stitches. It's a cute way during the OR. Put some drain, and an endoscopy. Everything was about 2 weeks later. You're going to be a huge disaster. It's terrible. It's all the abdominal cavity, the acute peritonitis there. And, the surgeon couldn't find, the hole. And what we did was wash everything, put a drain, and the patient did very well, but after 70 days, 70 days, at the hospital. Okay, so coming on this case.
So sleeve leaks are extremely, extremely difficult to treat because the sleeve is a high pressure system. No matter what you do, it is going to take a long time to heal, and there are many ways to skin a cat. Now, this happened during the primary case of doing a sleeve. And I'm assuming that he had sutured it. In Australia, we would have done a 4-quadrant drain anticipating this to give away. So one in the pelvis, both upper quadrants, and in the underneath the right, near the gallbladder area as well. And usually they give away. When they give away, you have the drains which, control the sepsis. And we are now doing a lot of endoscopic pigtailing, which allows the internal drainage to happen, which allows us to feed the patient, endoscopically, if required, and with subsequent, looking at the pigtail every time. You might need, if it's a big hole, you need 2 or 3 pigtails, and then, with each week you keep taking one off, and it usually heals in about 6 to 12 weeks' time. The advantage of an endoscopic drainage is at some point of time you can allow the patient to drink, which is a huge quality of life. The other way of doing what some people do is put a chest tube right next to the hole and actually externalize the fistula. So if you do that, you can actually send the patient home drinking, and the fistula closes in about 3 months' time. But then what you do with the fistula, if it ever reopens again, or if the patient has another operation for whatever reason, is what you need to answer the question. So many ways to skin a cat, depending on the clinical situation of the patient, the size of the hole, the comorbidities of the patient, and stuff like that.
Any comments, Kay, about this case?
Sleeve leak, we need a 1-day course for that. So it's very difficult to comment in a few minutes. But sleeve could be acute leak, could be subacute, could be chronic leak. Chronic leak is more difficult to handle. But acute leak, I think damage control, including control the sepsis, give the nutrition, antibiotics, and drainage is the most important. My own practice is lay some steps. For acute leak, we will go in to laparoscopic drainage. If the tissue is good, I will direct repair and do the fitting jejunostomy, put the drain. If it heal, then mostly after 7 days, we do upper GI series. It's okay. Then the patient can have the drinks, then go home. If it don't heal, then I would use the stent. The mega stent, the healing rate is about 50 to 60% in our own institution. So some patients would develop to become the chronic leak. Chronic, eventually they would need another operation to perform like gastric bypass, vestibular jejunal osmosis for that. In that way, to redo this kind of chronic in our center is 100% here. So I think that's the final step.
So the other thing that I forgot is that this is an acute situation. One of the other option is to convert it at that point of time to a Roux-en-Y gastric bypass, so that now you're converting a high pressure system to a low pressure system, put a drain in, heals within 2 weeks. That's what we've done in the past in the United States, so I forgot that. Yeah.
Any comment?
I think most of it has been already said already. I think the most important thing, of course, is the technique. I think maybe that when they were stapling at the time, so probably something would have happened during that period, I think.
Okay, my intention for coming out with this case is not the treatment of the problem, it's to prevent the problem. I think these stitches that the surgeon performed after seeing the blue is not clear. It's hidden, they are hidden the problem. I think, my humble opinion, have to be cleared out all the reinforcement, look at the hole and close it properly. The surgeon were performing a badly correction of this problem, right? Then can prevent, treat but the problem is because, in my opinion, many of the complications after the surgical procedure can be prevented during surgery. Look at the last case. This is my case. The other were not my case. This is my case. Okay? It's a SADIS procedure, right? If you see something wrong, please raise your hand and I stop the video. Everything looked bad, very, very nice, right? But you didn't realize nothing.
No, but you've taken the anterior wall without going to the posterior wall properly, so I don't know if you've taken the posterior and anterior on that side.
Okay, we'll see. We do the methylene blue test. Whoop. More blue, please. Wow. The blue is coming. The blue is coming. There is a hole there. And the way of solving the problem is not the same now that tomorrow. And worse, the day after tomorrow. So the importance of, doing things properly. Even the very expert can have some problem. Don't trust in those surgeons say, in my humble, in my experience, I never had a problem, no leak. I don't need methylene blue test because my anastomosis is perfect. Don't trust these guys.
People who say they don't have a leak, either they haven't done enough or they are lying.
Okay, so now the way of solving the problem is one stitch, the tissue is very clear, and then the patient did absolutely very, 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 very well. And again, come to Melbourne. Thank you so much. So you have some comment? Or
No.
Thank you, our speaker here. So we will, thank you very much. We will